written long, consecutive, consistent program running here, and I'm fortunate to be a part of all these rapid reviews. And at the very onset, on behalf of all the students who have passed and went out and had the benefit of attending this rapid review, on behalf of those students, let me in the beginning itself congratulate or thank my Guru Nandamar sir, my dear friend Padma sir, close friend and companion Dr. Devi, a very good friend Dr. Hari, and the entire crew of AZEEZIA Dental College for having this program still running in that same vigor and josh. So hopefully by the next year we will be adding more programs than the theoretical aspect of it, sir. Moving on to the practical, the review program also for periodontics, which you are presently having a 3-day program including the examination part. I think we should extend it into the practical aspects also of the final year exams, because it's not having a proper uniform aspect entire throughout the university as such. So some tips on how to make it a unified plan also should be taken up, I believe. Anyway, coming to my job, as she rightly said, last but not the least, to have, and sir already said it has to be an entertainment session because there are few students still alive out here. Anyway, I'm Precious from Department of Clinical Periodontology and Oral Implantology at Royal Dental College, Palakkad. Few days back, a few of my students had left that department to probably to join here. Hope they are still here.
Yes, sir.
Yeah. And considering the things that was being going on here, probably the last 2 days of brainstorming session, I was fortunate to have attended the last few minutes of what Dr. Baiju was saying. And probably I can understand this must have been happening in the last 2 days, and towards the end, being a Kochikaran, towards the end I think this would have been the situation of all the students out there. That obviously was Dr. Hari's presentation. This must be Dr. Harish's. Padma sir for relaxation. Yeah. Oh, that's the end of the interview. Goes up. Yeah. Little bit of family matters mixture in it. And finally, it comes out as Dr. Jay. So that was what happening in the last 2 days. I don't have much to add on to this rather than having a small entertainment session what Dr. Padmas are already being done. But to remind you, for the last 3 years, you've been dealing with this organ, which was taught as the most important structure in the human body, next to kidneys and probably pineal glands. And all those things what you've been taught about this particular the organ. Probably we have a small U-turn probably at the end of this presentation. Let's see. And you had your proper periodontal anatomy based on this. You had a periodontal histology, periodontal physiology, periodontal dental materials, periodontal microbiology. No short of any of basic science subjects or even surgical aspects of perio. We had a complete dental subjects based on perio in the last 3 years, including the perio prosthesis, probably we call it or better known as implants. We had a complete taste of all these things. It was a complete speciality of an organ. It's not just a procedure what has been taught to you in the last 3 years. It was all about a speciality of an area. It was all about speciality of a particular tissue that has been given just one single purpose, just to hold the tooth. But you had a whole 3 years, multiple subjects, all based upon this one but strength of this particular area, which holds tooth, which holds dentistry. Without this, there is no dentistry. And it was told this organ was linked to every part of the body, how it affects the other systemic organs or systemic part of the systemic area of the rest of your body, and how systemic diseases affect this. All those things were so detailed and very well taken to you all in the last 3 years. And you are aware of the importance of periodontium and its importance in dentistry, its general health. Too much of things being fed to your mind. But is our body aware of all this knowledge? This is what I doubt myself. Because tooth is the only organ in the body that has been mercilessly made mobile and forcefully exfoliated for having any diseases, whatever the reason it is. Whatever the reason it is, the treatment of the body or the way body treats teeth is absolutely different from what you've been learning in the last 3 years, that this is the most important organ in the body. But is our body aware of this knowledge? Tooth is the only organ which has been removed and has been shown to have the most unwanted and insignificant part or such an organ in the body. For example, see how easily it resolves a strong, well-functioning primary tooth root to replace with the secondary. Just imagine how easily it does it. Does it happen to any other organ? If any other organ goes into fault, does it mercilessly let it exfoliate? No, it doesn't happen. In permanent dentition, teeth are exfoliated by resorbing roots, and in permanent dentition, teeth are exfoliated by resorbing root support. You know, a series of events that starts from a small bleeding or a gum color change in the interdental papilla somewhere, and then later on slowly it results in a complete exfoliation of that tooth itself. A perfect diagnosis, perfect decision, perfect planning and perfect execution. A well orchestrated manner to exfoliate a particular tooth happens here. And it happens only with tooth, no other organ in the body. Because it is done from inside. Body has its own inherent and perfect way to throw away any unwanted or infected or destructive substance from the body. The same is applicable to the tooth as well. Even if it is the most hardest substance in the body just exfoliates itself if at all it finds to be an infected one. Body prefers this over this. It prefers to be edentulous, germ-free, maintainable and healthy instead of an over-threat of being infected and invaded. What makes body feel this teeth unwanted? Only body knows. Is it the germs and deposits or something else? Only body knows. But if the body feels it should go, then it will go. How does body weaken, shape, mobilize and exfoliate it and unwanted tooth? Just see. It slowly separates the tooth from its attachment by deepening of an area called gingival sulcus, which is a trench around the tooth, and little of periodontics we know about it. See, this is like a sulcus which is not there, which was not there during the birth of a baby. A tooth comes out and comes around as a trench around it, and finally when it deepens down, the tooth gets exfoliated out. Having said this introduction, let me come into my topic called periodontics, the pocket size. How important is knowing the pocket, or how important is knowing the gingiva and the sulcus around the tooth, and how does it impact the periodontal health? Keep about the body. We said body has got nothing much significant in retaining a tooth as such. Keep apart sentiments of your induced burden. How do you approach this condition when you have a chronic generalized periodontitis in front of you? Does the calculus around the gingiva catches your eye first? When you look into this picture, what catches your eyes first? Is it the calculus? By any chance? If so, you are fit to be an MDS hygienist. But if that gingival changes around calculus is going to catch your eyes, then you are fit to be an MDS periodontist. Have a closer look at this picture, because the entire presentation is going to be based upon this particular picture. Now, why do you think in those terms? Two reasons probably. You see only the deposits in these conditions, then start blaming the patient for this condition, and you strongly believe that this will never happen to you. Why? Why do you feel so? There's one reason is you know how to clean the teeth. And you think deposits are resultants of improper oral hygiene. measures and teaching brushing habit is primarily, you believe, is a periodontist job. And what's the second reason? Yes, you joined for MBS in perio because you are so good at doing this particular procedure. You have seen only scaling being done in the department. You've seen people coming in the department with so bad teeth or rather with bad oral hygiene. They go back with cleaner teeth, and this you've been doing in many ways, by non-surgically or surgically, one way or the other. You people are trained in doing it. And today probably are very good at doing this particular procedure of making an ugly teeth look clean. Now, are these deposits a resultant of bad oral hygiene, or is good oral hygiene a periodontist responsibility alone? What's the difference between an MDS periodontist and a dental hygienist? The same difference applicable with a nutritionist and a gastroenterologist, a pharmacist and a physician, a physiotherapist and an orthopedic surgeon, an eye specialist and optometrist. So it's the same applicable thing that runs in hygiene, a hygienist and an MDS periodontist as well. How many out there believe deposits are resultant of an improper brushing? Periodontitis is a resultant of oral deposit. Is it possible to keep teeth free of deposits? I'm sure none of you believe all these three things. See, what could be the reason why so much of deposits are seen around this particular tooth? Yes, that's absolutely nice. What about this area? That person has got good looking premolars and first molars, but towards the second molar, see, or in the picture on the left, you have got multiple teeth having calculus around it. What would be the reason? And what about this young lady who had come for scaling because of this bad oral hygiene, who said she's been brushing twice a day? What would be the reason that she's having so much of deposits on only one side of her teeth, or rather on the right side, upper and lower area alone? What would be the reason? Yeah. And that could be well related to this particular picture what you see out there. Plaque grows, calculus forms, and they are all just mere resultant of lack of usage. Lack of usage. If you don't use that teeth, then definitely something is going to grow. There's something very similar to what you see here in the countryside. So, are these deposits a cause for your disease or a consequence of your disease? Does plaque and calculus cause a disease, or are they consequence of the disease what you people have? They cause diseases. Plaque and calculus cause disease. Okay, so are we giving too much importance to deposits? Consequence of disease, focusing less on its cause? Are gingival inflammatory changes and periodontal pocketing being given less importance? Are these pocketing and further things happening over there harboring more of plaque and calculus in that region? So, do you still believe this is a causative factor? Plaque and calculus are causative factor for a disease, or are they just following the consequence, or are they becoming a consequence of that disease? No, because what is phase-one therapy in periodontics? How far is phase-one therapy a possibility? Is any therapy further needed if phase-one therapy is successfully accomplished? If you happen to have a very good phase-one therapy being done, the entire etiology being eliminated, etiologic phases is successfully done, do you think there will be any need for any further treatment in that area? Any need for any maintenance or anything? If you have done it properly and well, what about the other specialties in dentistry? They give one particular treatment and they don't ask you to come back and do any maintenance. But perio means it's an everyday maintenance that's required. His phase-one therapy we follow today, or rather what we understand is rightly the etiotrophic phase in periodontics. Should that be called as an etiotrophic phase? Does it really remove or eliminate the etiology from that area? Is etiotrophic phase is a possibility? Then why do we need a phase 4 therapy? If etiology is removed, then what is the need for a phase 4 therapy? Why do you have to maintain it again Is phase 2 therapy continuation of phase 1 or is it a substitute to it? Because you have done, you understand removing the plaque and calculus from an area belongs to phase 1 therapy. But that's the same thing what you do in phase 2 as well. You open up an area and do it. So is it because you have not done a proper phase 1 therapy that you are planning to do a phase 2 therapy? Are you going to surgically remove the plaque and calculus from inside? It is the same thing what you should have done as a phase 1 procedure. See, the reason why periodontal treatment fails is we spend less time diagnosing case individually. We try to make a single diagnosis out of 32 to 4 surfaces of diseases. We try to fit your case into a proper classification which is absolutely improper today. We focus too much on consequences rather than the cause. We confuse periodontitis as microbial infection, not inflammation or body's response. We are either behind microbe or a host player in the drama, not bothered about the real story, what's happening there. We don't communicate with the body in a very well or in the real manner. All the clinical features of periodontal disease, what we see as called as periodontitis, are just inflammatory signs. They are all aimed at deepening the gingival sulcus at a site or multiple sites. It is to untie the bottom of the teeth and expel the tooth out. So periodontitis is an orchestrated mechanism of the body to expel the tooth. We need to understand it. Since that's what the true cause of periodontal disease, if you search it to the corner, what they say in the model of disease. When you go through all these classic 4 boxes down there, you have got a microbial challenge, which is to be challenged by the host inflammatory responses. Then there is going to be a connective tissue and bone metabolism, and finally resulting in a clinical signs of inflammation, or rather that will result in either gingivitis or the periodontitis. The only way to understand the 1, 2, 3 and 1, 2 and the third boxes or the connection between this is the only thing what is available today, or probably in an advanced phase in impractical advanced diagnostic aid. You have got or rather heard about many advanced diagnostic techniques or tests by which you can identify these links between the first, second and the third boxes. Regarding the different components of AZEEZIA which will lead to inflammatory process and all those things, or rather what we have is an improper or inadequate or an impossible case recording pattern. With that, we need to identify the entire process of disease happening there. Only way to assess the 3 risk factors that influence the 2 and the third box. That is, you have got a host immunoinflammatory response and a connective tissue metabolism area, which are influenced by 3 risk factors. What are they? The acquired ones, the genetic ones, and the environmental factors. Do you think the case history what you generally do, or rather the generally being taken or recorded from a patient, is it sufficient enough to assess the risk factors, whether this person has got any kind of an environmental factors or an acute factors or a genetic factor that will influence the second and the third boxes, which will result in a clinical feature? Do you think the present case history is an adequate thing? Probably all the family, personal, medical, all those history what you ask them are so limited to understand what exactly is the problem that this person's periodontitis is a resultant from. And only the thing we left to diagnose is that last box. We cannot have any diagnosis out of the microbial challenge. I am pretty sure none of you up here sitting over here have seen a PGJ virus lively. Have you seen? Has any one of you seen a PGJ virus live? Have you seen that? Have you seen one? Any microbe in the oral cavity which you've been pointing as one of the resultant or the etiological agent to cause periodontal disease? Have you seen any one microbe? Now that is exactly what you said as a microbial challenge in the beginning. Okay, fine, leave it. Have you seen a WBC? A live WBC attacking a microbe? All you have seen is an arrow from the second box to the first box. Have you seen antibodies? Have you seen complement?
movements or any kind of humoral responses happening in the body. You have not seen anything, you have just heard about things, and probably what you would have been imagining or assuming is the shape of those germs and microbes that you see in toilet cleaners in the television advertisements or anything of that sort. Because that's the only thing that comes to your mind about a microbe when you talk about periodontal microbe as well, because you've not seen them. So the only thing what you're seeing about that disease is the clinical expression of that disease. That comes in the final box. And the moment you've diagnosed a clinical feature of periodontitis, you're already late. Because the last box is connected to the first box. Once you have a clinical sign of periodontitis or gingivitis which has already been expressed here, then that arrow is going to go and touch the first one. Once again, because it's going to be a continuous process. You have got a pocket in an area, you have got a gingival sulcus in an area, that's going to have the plaque, and the microbial challenge or that cycle is going to repeat again. So you have crossed the time to permanently treat it. So etiotrophic phase is a distant possibility for a site which has been diagnosed with periodontitis. The only therapy left is what? Treatment to prolong it from being exfoliated off, or treatment to prolong it to have that terminal treatment program, the final aspect of that particular disease. Now what about the other specialities? Is it that only we face this problem, or do other specialities treat the etiology first before they go in for the real treatment, like in orthodontists? Do you think they'll be treating the tongue thrusting and mouth breathing, all those habits before they go into really placing the wiring? Do you think so? Do you think those people are much bothered about this phase 1 therapy? You have to be more particular with the etiology first. You have to clear out the etiology and then only treat it. What about an endodontist or a prosthodontist or anybody who going for a veneering and all those crowns and all those things? They'll treat the reason behind the dental caries out there. The demineralization is treated first, then we're going for treating the dental caries. Do they do that? First, when a patient comes in, then they'll assess the enamel, the amount of minerals on each tooth. Then they'll send it to a nutritionist to get all the minerals being redone for the teeth, and then come back and do the dental caries treatment. What about an oral surgeon before removing that impacted tooth? Do you think that oral surgeon is going to assess the periodontal condition of that distal area of 7? How much of alveolar bone is left out there? Can something to be done to that area before they extract the tooth? Do they do that? And what about a prosthodontist? Before placing or replacing an edentulous area, do you think that person is going to take a detailed case history with all kinds of possible backlog of that particular patient, by the reason why that particular tooth is being lost from there? Do you think those people do that? Do you think so? Generally, many of the treatment becomes etiology for periodontal treatment, and they just hang it over periodontists after all those things that are done. Their etiological phase 1 therapy is going to be starting somewhere in the phase 4 or anything of their treatment, and it's not a periodontist who's going to come in. It's not the same specialist who's going to do it. It's going to be a periodontist who's going to do the maintenance part. Anything goes wrong with the class 2 cavity, it's not the part of an endodontist or a conservative dentist anymore. Anything goes wrong with an orthodontic treatment, it's not going to be an orthodontist headache anymore. Anything goes wrong with an implantology or an implant, it's not going to be the person who placed it, it's going to be a periodontist job. But do you think those people will teach us all these procedures, what they've been doing in the patient's mouth? No, they expect us to rectify all those mistakes that would have happened, all because they're not much bothered about the phase 1 therapy. How easy would have been their practice of the other specialties without periodontal disease? Material dentistry would have been so easy if gingiva could be ignored. Dentistry would have become an engineering science if gingiva and its sulcus had a little adjustment issue. See here. And if at all some amount of maintenance were allowed in between that particular teeth, instead of keeping that particular restoration there so closer to the gingiva, that area wouldn't have any issue regarding the gingival disease. If at all the margins for these cervical areas are spared, that will create a better maintainable area than giving some kind of a restoration closer to the gingival margin for this. See here. If at all this person had relieved some margin in the crown area. Definitely that would have helped, or if it didn't have violated the biologic bit, then that area would have looked much better and gingivitis or periodontitis would not have happened here. An orthodontist need to, if at all they didn't take a clearance from perio, before the treatment it's fine. But at least after orthodontic treatment, if they get a good consultation with perio, all these things can be solved to a certain extent. Do not ignore any kind of an endoperio lesion, or should not be ignoring any endoperio lesion happening in a particular area. If at all they have to go in for a crown over that particular tooth, that's going to harm them later for sure. And no comments I believe. Since somebody tried to place a pin or a post and core which is going to impinge into the interdental area or to the periodontal aspect, then okay, then there is no point in having a comment over it. See, some marginal respect had given to this area. Do you think the gingiva would have had this color? That's absolutely a cyanotic gingiva which was not at all, an aesthetic one. Which probably a person placed it, a prosthodontist or an endodontist or a conservative person, but placed that crown had no idea regarding this particular area, will change it to a cyanotic colored gingiva later on. Furcation defects. If a person had an idea what exactly will happen to a furcation area, if a restoration like this being given or a tooth is being tried to be saved by some kind of a pin or a core or a restoration being given here. See, a restoration being nicely done by placing the two class 2 restoration together into an interdental area results in a periodontal pocket. And even when you have a diastema closure to be done in a central incisor, you didn't give enough space in between for a force to pass through. You jointly place a composite restoration between two central incisors. That area is going for a gingival or a periodontal problem in future. See, if at all a restoration of a canal, a root canal treatment has got an extension of a GP cone extending into the periodontal area. It's not an endodontist job anymore. It's going to become a periodontal pocket in future. And of course, in cases of drug-induced gingival enlargement and all those things, whatever you ignore and keep, that's going to result in a larger coverage of gingiva by the hypertrophy of the gingiva that becomes very evident in future. See here, its karma follows, so definitely follows. It is all like ignorance of furcation area being done here. That is not going to definitely be forgiven by gingiva. That's going to grow into a periodontal pocket, and definitely that will result in periodontal abscess. If you have not restored a class 5 restoration in the way to call it a restoration, if you have done a filling over it without being much respected to this the theories out there, that's going to result in a gingivalization in future. The same thing as we said, if at all the area behind the tooth, the area behind the 7 has been nicely sutured or some kind of a bony filler being given there properly, that area wouldn't become a periodontal pocket in future. See here, if the tooth is being prepared for a crown, but definitely no any kind of respect is being given to the marginal ridge of the nearby tooth. It's not that the restoration doesn't become complementary to the marginal ridge. They've instead tried cutting the nearby tooth as well for a preparation. That's going to lead into food impaction in that region, and that's going to become a periodontist problem. See, a right margin not being given to this particular prosthesis, that's going to result in another gingival problem. So none of these things are being forgiven by the gingiva. Body always prefer a healthy edentulous site. Whether you like it or not, whether you are a periodontist or not, body is always trying to favor a very healthy edentulous site instead of these areas that are very much under threat. This is what basically body wants to tell you. Periodontitis is the way body achieve it. How does body achieve a very clean oral cavity? By exfoliating of all the teeth. Gingiva is the structure that keep this particular area under check all the time. And sulcus, this forms the wall site of it. Gingival sulcus was never there at birth. It came along with the tooth at the time of eruption of tooth. It disappears once the tooth exfoliates off, and it reappears once you place an implant. And then it disappears if implant goes off. It wasn't there in the ridge. When you open a baby's mouth and see, you don't find certain gingival sulcus area through which the central incisor is going up. It was never there. It was not part of the body. It was never a part of the body. And body treat that particular area as something foreign as well. See that oral epithelium, that tooth slowly came up. It emerged into the oral cavity. Then from that particular point, it started developing a sulcus around it, and finally that same sulcus deepens down and the tooth exfoliates down. It is something like a trench around the fort. It is going to have a trench around the tooth in the gingival sulcus area, which is filled by water. We call it GCF, right? Something like this. It is a trench around the tooth. It has got some liquid inside it. That liquid is primarily a transudate or an exudate. It is primarily a transudate that forms a sulcus, and the fluid inside the sulcus from the osmotic pressure of the tissue around it. And if at all it is infected by microbe, it becomes a exudate. So it is primarily a transudate, later on becoming an exudate. It has got all the kind of all possible poisons kept inside it, and this particular area which you say as a gingival sulcus area filled with fluid, this is very much needed for the WBCs to have its activity going on here. Though this area is formed because of the microbial interaction with the body, this area is primarily required for the WBCs to have some action over the microbe which is stuck to the other side of the tooth as well. So how to manage this sulcus deepening? Keep apart all the phases of treatment and ignore all the etiological factors. If you don't believe in postponing a treatment of a patient until the right time comes tomorrow. For example, somebody comes to you for some kind of a treatment and you think an etiotrophic phase is impossible for him. I would ask that patient to come after 20 years to do some treatment so that a better treatment will be available for you. Can you do that? So you have to do something to the patient. So that a patient has come with some kind of gingival problem or a periodontal problem, you cannot ask that patient to wait for another 20 years. Something good will come out from the researcher's side and we'll try it out for you. No, you have to do something. So all the treatments what we have learned from Perio today probably are all compromised treatment. We need to understand it. They are not the only treatment possible in the generations to come tomorrow. Whatever we will learn as flap surgeries or gingivectomy or curettage or anything what you do today or your people being trained, they are all techniques and procedures that are available today to manage certain conditions, and definitely you should be able to change your mindset into some other treatment or a better treatment that's going to be available tomorrow. So the goal of periodontal therapy presently is to create a naturally maintainable state of periodontia. So it's not that every case has to go in for a treatment that will aim at a complete periodontal regeneration and to achieve the complete new attachment procedure. Management of gingival sulcus is just allowing it to be self-maintainable. The gingival sulcus depth has to be reduced. The size of the gingival architecture has to be brought back to a normal level. All those things have to be maintainable in its existence. It is all because all our attempt to analyze and understand and control the first three boxes and the three risk factors, they are all the particular the model of pathogenesis of disease what we know. It needs to correct issues. The last box is welcome. Anything that is to be done to correct that last aspect or the clinical features is welcome. You cannot just go behind the etiology of each and every diseases or rather each and every aspect of the periodontal disease that you see. You can just focus on the clinical features of periodontitis or gingivitis. The clinical feature of periodontitis is gingival color, the change, swelling, size of gingiva, the pain, the bleeding on brushing, pocketing and mobility. So keeping apart all those exact things what you know in the first three boxes, the clinical features of periodontitis or gingivitis has to be treated. For example, you have such a condition that has come, such a condition of a person who has come to you, and you surely know this person is having some kind of or consuming some kind of a drug that is inducing this gingival enlargement. You ask him, he says yes, he is on amlodipine drug. And now you see a picture where we have seen a gingival enlargement in the textbook. It is exactly resembling the same. The patient has got a history of having this particular medicine also. Now, what are you going to do about it? Are you going to ask the patient to stop the medicine right away from today? Can you do that? No, you cannot do that. You see a lot of plaque and calculus out there. You see an inflammatory enlargement also. It is not purely fibrotic. So, you know what to do. You have got a model of pathogenesis in front of you. You have to do a phase 1 therapy. Here, phase 1 therapy is not scaling and root planing for this case. Phase 1 therapy is definitely stopping of that drug. Now, can you ask that patient to stop that drug? What if nothing happens after that? It is like it has got a lot of plaque and calculus over there. So, you do the oral prophylaxis, and you happen to have this case being changed into that particular condition. And now, what can we do about this particular situation here? You have done a thorough root planing here, you have done a thorough scaling, your drug-induced gingival enlargement is almost running around here. It's like you almost know this is going to be the diagnosis, but you are not sure about it. And unless and until you stop the drug and wait for the next 6 months, you cannot make a diagnosis. So, drug-induced gingival enlargement diagnosis can be done perfectly or rightly after 6 months of stoppage of this drug, and if the lesion seems to be getting completely resolved. So what will you do about it? So you take a sword and do a little bit of work over it. So what do you do? Do a gingivectomy or a NAP procedure or a cure-attached procedure and give some relief to the patient. So what happens to your phase 1 therapy, which has to be done first, which is to be followed by a phase 2 surgical therapy, totally ignored. Why did you ignore it? Because there is no other option. So flap surgeries for pocket elimination. They are often methods to favor natural maintenance of the gingiva. Whatever the reason for the pocketing is. So if you go behind asking for what exactly is the problem that has resulted in the pocket formation, definitely you are not going to do any treatment for that case. You are going to keep on looking for the reason one after the other which will get added by itself. So you are going to do some kind of a treatment over there that will reduce and forms a particular area that which will be maintainable for the patient. See here, your patient has come with some amount of periodontal pockets that is seen in the anterior region. Now I am going to do an investigation which will be purely or rather directed towards knowing the etiology for this pocketing, or I am going to do a treatment for pocket. Rightly said, as textbook says, you should be going again what exactly is the problem with this patient, which would be directed towards the microbial factors and post-bacterial interaction and all those things. Instead, definitely, you are going for a radiographic analysis. How much is the bone loss around that tooth? What kind of a bone loss is that? Assess all those things, and then you are going for assessment of a pocket depth. So after knowing all those advanced diagnostic aids and advanced methods of assessing disease, you are finally relying upon the most basic method of assessing a periodontal disease. That is just how much is the pocket depth. So then what was the point in knowing all those things what you have learned in the last 3 years? All of the years, whatever you have learned is being kept apart. Only thing what you are going to assess is how much is the pocket depth. Because you know the treatment is going to be totally relied upon the pocket depth of it. The assessment of the disease progression is going to be relied upon the pocket depth of it. So the entire focus is going to come into a clinical feature of disease what you see in front. And you don't much bother about the real etiology, the real cause of this disease, nothing of that sort. You just focus on the pocket, the radiographic findings, and what kind of radiograph would you be suggesting to give a clear picture of the bone loss? Do you think for a periodontal disease you can go in for a CBCT examination of knowing all the periodontal, the weakened areas around the tooth? Is it possible with you? You are not going to do that. You are going to rely upon simple IOP or something of that sort. Fine. And then what you do? Then you finally assess this particular case to have a particular treatment reduce or eliminate the periodontal pocket. So the aim of the treatment was never a complete periodontal rehabilitation. Do you think you will get a case in a private clinic outside wherein you are being given a case of periodontal pocket or a mobility case, and the doctor expects you to place some bone grafts or some kind of a guided tissue regenerating membrane and all in the periodontal area and regenerate the entire thing and give it back to the doctor? Do you think you will be given a patient in that way? You will be given a patient who has got a complaint of bleeding gums, mobility, so some amount of pocket things, some periodontal abscess and all those things. You will be checking for the periodontal pocket depth throughout the oral cavity. You will be telling the patient you are having a pocket in these areas. Now what is going to be the treatment? I am going to assure him a complete periodontal total rehabilitation and do that. All you can tell him is we will do some kind of a surgery to you which will reduce the pocket, which will reduce the periodontal inflammation or the chief complaint or the clinical features that you are suffering. That's all. You cannot assure a patient for a complete new attachment, you will bring your gingiva back to what it was in the age of 16. No, it's not possible. So you will formulate an objective of management. It is absolutely pocket elimination. My dear children, all these slides, what I have been telling you, what I am trying to impress upon you people is, whatever you learned from your last 3 years, these are not the cases waiting for you outside. You will be having a complaint from the patients with regarding to the clinical features of your periodontal area. And they don't expect you to give a wonderful result of their smile back to the age 16. All you need to do is some kind of periodontal treatment which we will follow now. So a pocket elimination and restoring the gingival architecture back to a place of maintainable situation. This is all you need to know. So what are the surgeries available for this? To reduce a pocket or eliminate a pocket or to bring a gingival contour back to the normal maintainable state? What are the surgeries available? You have got a procedure called curettage with you. What do you have? You have a procedure of curettage. And what will curettage achieve? What can you achieve out of a curettage procedure? Some amount of inflammation reduction, a good pocket lining removal. So that will result in shrinkage of the pocket. That will result in a firm gingival architecture. So that will definitely eliminate the possibility of bleeding on brushing. Fine. Some amount of what kind of an effect is going to give? Some freshness in the oral cavity. So that becomes a preparatory procedure for something else in future. If you want to still check that patient after a few days and see, and if some amount of pockets are remaining in some areas, some residual pockets are remaining, what do you suggest? A gingivectomy? Fine, if gingivectomy is okay, gingivectomy. Or else flat surgery. Now what's the difference between choosing a procedure of gingivectomy or flat surgery over gingivectomy? There was a time like our seniors over here, my teachers over there had only the procedure of gingivectomy done for any patient to come to you with a periodontal pocket. It was only gingivectomy. You will measure the amount of pocket there, you will put a cut of that particular area, you will remove that tissue and throw it away. That particular area is absolutely devoid of periodontal pocket. That is only treatment available. But when we started understanding gingival contouring is possible only by contouring the bone underneath it, then came something else called a flap surgery, which gingivectomy procedure is being modified, or the pocket elimination procedure is modified into such a way that you can have an access to the underlying area and just some amount of bone around the tooth, thereby achieve a good gingival contour. A good bone contour underneath the gingiva will definitely give a good gingival contour over it. So flap surgery was preferred over gingivectomy. So what looks like, particularly this case, whatever you have seen as multiple pockets in the upper anterior region is being assessed by radiographically, and you have found multiple bone loss is being there in those areas. Now the patient has got a complaint of, what could be the patient's complaint? Patient doesn't have any chief complaint related to the periodontal area at all. The patient had come for something else, or patient would have come with a complaint of probably bleeding on brushing or something of that sort. The dentist in that clinic would have identified some periodontal pocket in his mouth if at all there is an equipment called periodontal probe in his clinic. If that is also not there, then that diagnosis is also gone. So nobody comes to you with a complaint of a periodontitis. They come with a complaint of something totally different. And you or the dentist in that clinic is going to diagnose a periodontal pocket and give it to you. And you are going to do a procedure which probably will look uglier than a preoperative procedure at the end of your surgery. That's what you are going to do now. See what you plan. Now there is a pocket over there, you have convinced the patient, and the patient is also convinced. And you are going to tell him, if at all you do a procedure like a flap surgery or something, this is going to finally loosen your teeth. The patient is somewhat convinced, and you are going in for a very good flap surgery. Probably if you want to eliminate the gingival contour, if you want to the rest of the gingival contour to a normal level, if you want to do some kind of a bony adjustment in the underlying bone, all those things. And if you want to add on some amount of attached gingiva to the existing pocket area, you would prefer what kind of a flap surgery? Out of modified Whitman and undisplaced flap and apical displace, if you want to do a complete elimination of the pocket, if you want to have a good gingival contour, if you want to have a good bony contouring of that area, and plus you want to add some amount of attached gingiva to it, which would be the right flap surgery? Apical displace flap surgery, fine. So you go in for that apical displace flap surgery. The incision is what? A good, neat internal bevel incision, 0.5 or 1 millimeter away from the crust. Fine. So that that blade is going to be directed towards where? It's going to be directed towards the bone, the crust of the bone. Then finally you got a picture like this. That incision is being very well placed. And you remove the tissue and you get an area wherein your internal bevel has separated out the sulcular epithelium and junctional epithelium out. So you have got a nice gingival flap being elevated, and what you see there now? A bone which is exactly corresponding to the disease that was happening there. It could be irregular, it could be bulbous, but definitely that's going to definitely dictate the gingival contour that's going to form over it. So you want to do some kind of a bone contouring that will favor a good gingival contour in future as you suture it out there. And finally a suture is being placed there. So now what have we achieved here? A complete pocket elimination, haven't you? Yes, then a complete removal of the pocket lining and all those area which you would have done by curettage procedure that is automatically achieved by an internal bevel placement. Right? So that is being achieved here. A good bony contour is being restored so that the gingival contour over that is properly seen. See here. The postoperative probe depth, if you see, what will happen here? Would have reduced. That was an area which had a proper gingival coverage till CEJ. And the patient look into the mirror, what the person sees is a good gingival coverage. After your surgery, what will be the condition? See this left side, what you see here over there was the condition of the patient came to the clinic. And see what is going to be his condition after the surgery? The tooth has become longer. So which is more ugly or which is better looking, the pre-op or the post-op? According to patient. Now what are you going to tell the patient? Every other speciality has got a wonderful post-operative result compared to the pre-operative. Perio has got this reverse effect. If you go in for a real good perio, what you learned in the last 3 years, you are going to land up in this problem. Now, how will you tackle this? The patient is going to ask me, now I came with a shorter teeth, you have made my teeth longer. I came with a good smile, you have made it ugly. Now, if you could have told the patient prior itself that, what? You're going to make them ugly? Is this what you're going to tell the patient? Do you think that patient is going to sit on the dental chair? I told you in the beginning, the patient never had any complaint also. Regarding a caries, regarding a dentulous area, regarding crooked teeth, they have not complained. And after the treatment, you are going to rectify that complaint. What was the complaint of this patient when they came in this condition? Nothing. Patient never tried to drop that area and found some pocket, and the patient was referred to a periodontist, and you came in. You came into the picture and you told the patient, yeah, what that doctor said is right, you have got pocket. I am going to do a surgery. And the patient opened his mouth and kept open for 1 hour or so, and finally you are going to show this particular thing in the mirror. And your teeth has become the real answer to that particular condition, whether the patient believe it or not, is you want the tooth to become longer or you want the tooth any longer. This is the reality. This is the reality. Your tooth becomes longer but minus the pocket. Your tooth has become longer, your gingiva has shrunk down, but it is healthy. If you cannot convince this particular situation, children, don't start your periodontal practice. Even if you cannot convince this particular situation to the doctor who gives you patient, don't start your practice. You will be totally disappointed. Your definitely periodontal treatment will result in an uglier look, but healthier look. Yeah, definitely. So all those things about the bony architecture what I have said here, please bear it in mind. You are going to make it uglier in look, but healthier in situation. So the gingival contour can be restored and all those things. Fine. All these compromised periodontal procedures were aimed at one point, establishing a maintainable state of periodontia. See over there, this particular patient is having a healthy periodontium, understood, but that is after a flap surgery. But definitely the look has to be, definitely that the patient has to bear it. So now, did that end the treatment? No. We have always a phase 4 therapy between every phases of your treatment. That has to be followed up. Why? Why does a phase 4? Why should a phase 4 come after phase 1? Why should a phase 4 come after phase 2? Why should a phase 4 come after phase 4? Why should it come so? Why? You have still not touched upon the etiology, please. You have still not touched upon the etiology. This is why the model of pathogenesis of periodontitis was put in the beginning. You had 4 boxes which said microbial challenge, post response, then a metabolism of soft and hard tissue resulting in clinical features of periodontal disease. Am I right? Microbial challenge. You cannot see the microbe, you cannot see them also. They live in a different world. Even if you start seeing them, they will change their faces. So it's not, there is no point in knowing a microbe, you cannot. Now what about the second box? You have got a post-immunoinflammatory response. Are you going to see any of those molecules of cell or cells that are going to fight with the microbe? No. You cannot identify any of those things. What about the metabolic changes that are going to happen in the soft tissue and hard tissue? No idea. You don't have any idea about it. All you know is some radiographic change or some kind of a color change or an edema or something happening in the gingiva. No idea regarding anything happening inside. Only thing you know or probably appreciate is clinical features of periodontal disease. You can change it. But changing it doesn't mean that you treated the disease. By changing it, you have made it a maintainable state of periodontium. That's all. So that's the same thing. And this, what makes all these 3 boxes that you see in the disease model impossible for you to conquer is those 2 risk factors seen on top and down. Genetic. How far can you take a case history of a genetic change that has resulted in a disease for a patient? You can ask that patient whether your father has got a similar problem, your mother has got a similar problem. Do you think that the patient is going to respond so lovely if you ask him whether your grandfather's father had this problem? Do you think that patient is going to answer such a question the way you wanted him to answer? Probably the answer will be slightly different from what it was when he had asked whether the father had the same problem. So all you can ask them is about some kind of a family trait, whether it's there in your, whether it's there precipitating as your disease. But what difference does it make? Yes, my father had a bad periodontium. Now, does that mean my third molar or the second molar distal area is going to have the same problem because my father has this problem? Because my father actually didn't give birth to me. It was my mother. So some kind of a mixture has happened here. So now what is the genetic factor that is running in my family? I don't know. Now what about the acute factors? Whether this person had some kind of a disease at the age of 6, who knows? Whether this person is having a trait of diabetes in him, who knows? Acute, environmental factors, how much can you spend or how much of a case history can be taken to know these risk factors of the patient? But mind you, all these risk factors has got profound effect on the clinical feature of whatever you are seeing. So all those things have to be kept apart. See the environmental factors. 25 to 33% of this disease are contributed by environmental factors of any disease for that matter. Now how far are you going to go or how deep are you going to assess the environmental factors that has happened to this person by asking him his name or age or anything of that sort? Acute disease. Whether this person had any kind of disease at any point of time that has resulted or contributed to periodontal disease or that has resulted to some systemic disease that is resulting in this disease, no idea. Now as long as these three risk factors, the acute, the genetic or the environmental factors, they prevail here, our diagnosis will remain improper. Please understand this. Whatever you have learned about periodontics in the last 3 years, if these three risk factors are not properly understood, or if you don't understand these are going to have some influence on this particular person's clinical feature, then your diagnosis always will remain improper. Your treatment plan will be always changing, ever changing. I'll give you a small story that has happened with Nandagumar sir. Nandagumar sir was in Libya. So that time, his first visit to Libya, that time, a patient had come to him for a treatment. He said, you have to do some kind of a treatment to treat this. You have to do a flap surgery right now, otherwise you are going to lose your teeth in the next 3 years. Sir happened to came back and again visited that place after 5 years. The same patient came to him and sir said the same thing again to the patient. You have to do some flap surgery right now, otherwise you will lose the teeth in the next 3 years. He said, sir, you have told this 5 years back. The teeth are still there in the oral cavity. Your assessment went wrong. Why? Why did the assessment goes wrong? All these risk factors plays a significant role in making the disease worse or even making the disease reverse back also. So these risk factors are so strongly involved in it. Your treatment for perio is never ending. Once a periodontist patient is always a periodontist patient. Let not your periodontal practice be in this order, where a person comes to you, you diagnose a disease, you tell him it is periodontitis. So what to do? What to be done? Okay, going for a phase 1 therapy. What are the phase 1 therapy possible? You can give these many things to be done. If not successful, then you plan for a surgical phase of therapy. If that is not successful, what do you do? Okay, you ask him to extract the teeth and going for implants. If that implants fail, then all on 4 fails, you will get all on 4 fails. Okay, you have got still options of other implants. Now, what do you start with? You started with the perio complaint, which you don't know what exactly is the prognosis of this condition. You could have asked this patient in the beginning to go in for extraction and get the right implant. Am I right? So, a slight mobility of some tooth. A little bit of mobility or a little bit of periodontal disease in that area, this area. Try to visualize what is going to be this person's condition after 10 years or 15 years and plan the treatment accordingly. You cannot start doing a periodontal treatment for a patient who has come to you with a periodontal complaint. The patient comes to you and says, my teeth are slightly shaking and you happen to check for the mobility and you find it to be a grade 1 mobility. You are already reached a condition where you cannot do anything. Please understand that. I used to violently oppose this particular idea what I said right now. Once upon a time, when I was in my post-graduation completed period, when somebody says a grade 1 mobility tooth has to be extracted, I used to violently oppose that idea. I used to say, no, then why did I learn perio for? It's not anybody else's patient problem. It's not a patient problem. Just because you are a hardcore periodontist doesn't mean that all the mobile teeth has to be restored by you. and don't think you can do it also. Don't make any heroic attempt of retaining any mobile tooth in the oral cavity. Did you hear me? Because there is no single chapter in any of the perio textbook that gives treatment for mobility. Did I say something? There is no single chapter in any perio textbook that suggests the treatment for mobility. Did I say something? Did you hear something? Have you seen a chapter on mobility? A chapter for the treatment for mobility? Is there such a chapter in KR, sir? There are chapters and chapters on periodontal treatment which suggest the management of periodontal pocket, acute gingival condition, many such things, periodontal plastic surgery. Have you found any textbooks that suggest or gives you treatment for tooth mobility? Once a tooth is mobile, please understand children, that means body has started to dislike it, body is expelling it. You don't make a history, a kind of a heroic attempt to retain that tooth there, because a tooth mobile in one of the areas is going to give a picture what you exactly saw when I showed a dental case having a complete calculus around it. The tooth is mobile here. The patient is not going to chew with that tooth. That's going to definitely result in multiple areas of bone loss. That's going to result in an area which cannot accommodate a implant in future. So here finally made this patient end up in a condition where a periodontist has been so successful in motivating that patient to retain his teeth and somehow manage with that mobile condition, landed up in a condition where that patient cannot now place a good implant also. So mobility doesn't have a treatment as such. Okay. So in that condition you have to come out of your conventional thinking box. You definitely have to come out of it. What is the way out? Yeah, definitely. See, this is the normal way probably you learn a textbook or read a textbook. This needs this kind of a small disturbance to you. Whatever you read from a textbook may not be having the same meaning by the person who wrote it. You might be reading it in a wrong way. So you need a definite change from your comfort zone. Do not think 3 years of your MBS training gives an answer to all your problems in perio. Last 3 years your problems were actually our problem. Now next, once you complete this course, then your problem is going to be, it's going to be your problem. You're going to be a hardcore periodontist. You won't suggest anybody placing an implant. You're going to be a hardcore periodontist. You will definitely retain if that tooth is even greatly mobile. All those things, then okay, fine, go ahead. That problem is all yours, because we had the same kind of thinking once upon a time. So basically what you need to do is, you escape from your textbook, not right now, once you complete your course. Because this is another point where you have to memorize all those things what you have learned and put it in an answer paper and pass out and go. Come out of the teachers, not be too dependent, because many of the things what I am teaching you may be things which was taught to me by my teacher, which was taught to him by his teacher, which was taught to him by his teacher. So finally, the net things, many things what I teach here, I mean the things which was taught by some teacher to some of my great teacher in the year 1915. So please understand, please come out of the box which is absolutely comfortable. Don't get tied down with what you're good at. You may be very good at scaling. Now that's not your field of practice. Now you have to come out of it. It doesn't mean that you should not be doing scaling. You're good at it, come out of it. If you find yourself good in one place, then that is the end of the time you need to be there. Now come and find out what you're good at in the next level. Keep updating. Keep updating. This is one thing I would like to appeal to you all. Please keep updating, and you will be at 2024 right now. So kudos and all congratulations to this team who has shown one way of updating things.
It's like these people have been showing these things throughout the last 10 years. They had a very bad corona period also that came in between. Still they were so belligerent to keep on doing the same thing. And all big thanks, as I already said, from all the students who have already passed and moved on. Now the message from these people who have been consistently doing this is, please update your knowledge. Don't get tied up in textbooks. You need to update the skill. You need to update the talent, also to update the knowledge. And all thanks to this great team of AZEEZIA for giving me this opportunity, and definitely all to have a feel of the entire 3 years in the last 2 days and continuing in the events to come tomorrow.